Some of the same, some of the new, I don't know.
Keep going.
Yeah, I know.
Ever ready bunny.
That's right. Just keep banging away.
Think about retiring yet? Or
The sooner the better.
Yeah.
retirement on the plans
Chuck asked.
soon?
Yes.
I'm trying to find out how to slow down, not retire.
Yeah. I mean,
You know,
Having too
I-
much fun
I'm
stationary.
Yeah, I'm having way too much fun. You know, I reconstruct chest walls now. Titanium.
Absolutely.
That's what I do.
What do you do?
I work with spine surgeons.
Oh, is that right?
And we reconstruct chest walls and babies
Okay.
with bad chest wall
You
deformity.
said that. I had to think about that.
No, it's all pretty cool device, novel device.
So they haven't given me
Is that right?
Most of it not FDA approved. So.
Are you the inventor of this stuff?
No, I have one of my own I'm working on, but
They haven't given me another date yet.
it's working
so.
with the inventor of the first thing. I met him at a cocktail party in 2001. We've been working together ever since.
Is that right?
Yeah.
Sounds like fun.
You get yourself a 3D printer. Printed chest wall.
I know. Well, you know, actually, I got to do a 3D printer and print the ribs.
They're getting cheap enough here now. I heard. Like, you can get them for $1,000 now. They figure they'll get down to $300.
Less than one of the papers that had some of these strange uses of 3D printers. One that somebody's printed a face.
Oh yeah,
These guys.
yeah. We've done faces. And we've done all the negative space in your face, like all the air. See how it's connected?
Yeah. My dentist says he's using that 3D kind of imagery for crowns now.
Oh, is that right?
Do that. You don't have to make a mold and send it.
Yeah.
That's been around for a long time, but the original, they've had
So the
dental
equivalent.
engines that do that for at least a decade.
I wish it would save me money
It
on the
wasn't as
crown.
accurate as as properly done.
Because you have to change everything.
Yeah, but I bet you the software has fixed that.
Yeah.
Kodachrome.
Yeah. Cool stuff.
Those days are gone. 201 today.
Yeah, but devil worship.
Don't talk to me any idea.
Well, you know, Wicca is the fastest growing religion.
Yeah, because only 3 of them, one's going to that's 25% increase. But Gary did last week's on religion, and I can always give you one topic that's not allergy medicine.
Joe Martin
Last year. Actually, gave me check
doing
That's a good one too. I'm still fascinated by the Krakatoa eruption that supposedly happened back in like year 83 and changed the world's climate for years.
Oh, you know, I did. Well, yeah, I know. I mean, that was a great topic. I really enjoyed that book by Winchester.
Still got Joe.
Well, last history
Busy but good.
all of that.
Yeah.
The Eastern religions in particular. I mean, my thought actually when we were done was how amazing human imagination is to make up all this stuff. And then believe.
That's
So
amazing.
that's the crazy
You know,
part.
DeGrasse, you know, the black guy,
Yeah.
was very good. He said, what frustrates you the most? What frustrates me the most is many things are abjectly false. That's what
Jared's great, no matter what it.
But you know what? Imagination is a great thing. And it's wonderful and it creates life, it creates others. It gives hope and everything else. So you can't rock.
But you know, when I come to
My next rank is American.
wasn't the name of
Survival of the fittest, I guess.
We put my community life in. They're all going constructs. Spinal growth. Everybody is doing it.
Yeah.
It's part of the progress. Well, you have to get the transplant. You take care of it. They all die.
There, you get one. Well, that's
Gregory.
How are you, Mike?
See you.
Well, we're going to all right, my friend. You gonna aspirate? It's that time. It's that time. I took mine off before I came. I said, no, I'm a pediatrician.
You're right.
In Seattle, you know, come on.
oh, awesome. Thank you so much. Don't forget too much. They never range, you need to chug.
Yeah, that's right, yeah, exactly.
Can't get any more of that.
Looking back at what you guys are going.
I got trying to survive.
Survive what?
Birch.
You're allergic to birch and I don't know.
I don't know. I'm used to living here.
Yeah, it's wonderful when you show up here and
My body has adapted.
in the wrong way.
I know, quote unquote, adapted.
In a self-destructive way.
So my symptoms are
So most of them.
I can't wear my boots.
Actually, most of
So last year I was wearing
Oh, yeah.
we're working on
Yeah, I love it.
Hello, darling. How are you?
Oh, I know. I've been sick so much. Is it a nice Chicago boy?
kids use theirs and they get a whole liver worse for it, they take all ours away.
Really?
It's a one-time use. But it's awesome.
One strike you out.
One strike you're out.
So, long story short, I only went half day on Saturday. We were on schedule, so I only went half day. Were you up there?
We were there, but the weather Saturday was better than Sunday because it was sort of clear up.
No lines. I got there 7 runs.
And 7 runs at North only about 30
I've been up there so long.
They've made a lot of changes. Well, we have a timeshare we're trying to sell, and then we got more property than we can see. Quarter shares are not selling. We're going to sell them.
I went around.
I kept saying to my wife, live ahead somewhere, and I said, it's over, but you definitely, it wasn't.
Hey, Bill. Billy meeting up.
Coming down high-five.
I'm actually meeting with Gabe prior. I think we figured out.
Get the lights and get my.
I'll explain.
Yeah. You're going north. No, you're going south. That's right. You don't know. That's a nice place to work. But I just go past Green Lake.
You marked your
Let's go ahead and get started. This morning's speaker is Gregory. He's a longtime friend of many of the people in the room here, and professor in pediatrics in pulmonary over at Children's, and is nice enough to come over. He's going to give us a talk on acetaminophen and pediatric asthma. And then for those of you who have time, either in the room or those in our web audience, David Hagan is going to present him a case, and we'll have a little bit of an additional discussion. I don't know the content of that case, but hopefully it'll stimulate some good discussion. Greg?
Great, thanks, Len. Good morning, everybody. And those at home, in your pajamas. Thank you for asking me to come. I want to talk about a topic that was purposefully provocative in pediatrics about a year ago. And you can start with this talk if you like, based on the last slide, which is the one that really stimulated my interest in this. And it has to do with acetaminophen and its relationship to asthma. And to make a really long story short, there's a burgeoning literature on this and a persistent interest in it that I think is intriguing but not necessarily convincing. And for those of you, I'm disclosures for CE. I'm an editor of Up to Date, one of them, one of 250. And I'm a member of the DSMB for the Asthma Research Network. Let's start with this. This is all common knowledge to you, so I'm not going to belabor it. This is a slide that shows the relative prevalence of asthma from the 50s on up to the mid-2000s in about 33 different countries using the ISAC format. For those of you who don't know what that is, that's the International Study for Asthma and Allergy in Children. And we were part of that for quite a while, and it is an international network that using standardized questionnaires that are culturally sensitive in the sense that you show videos of children of different ethnic origins to identify symptoms of asthma. And using that kind of format, people have been looking at prevalences of asthma at least since our first ISAC was in 1991. So some of this is retrospective, but you get the general idea that the prevalence of asthma has been going up over a variable amount of time and rather rapidly. And independent of the guidelines, I'm not going to talk about treatment today except as it relates to acetaminophen. There's been a lot of discussion on why this happened, including the hygiene hypothesis, which has gotten a lot of play. And one of the things that kind of somebody had the intuition to look at this had to do with aspirin and with NSAIDs and with acetaminophen. And for those of you who have as much gray hair as I do, you remember a syndrome called Reye's syndrome. And Reye's syndrome was a bad disease associated with influenza, infections, and chickenpox. And in children who had aspirin as part of their antipyretics for treatment of those syndromes, developed hepatic failure and intracerebral edema and herniated. So when I was running the ICU back in the old days, we would see a ton of this, and we were trying to control intracranial pressures, and a lot of kids died. And we didn't really know very much what we were doing, and we certainly didn't understand the pathogenesis. And I'm not sure people still understand the pathogenesis, but what they decided on was the epidemiologic relationship between aspirin ingestion and influenza-like illnesses. And as a result of that, in a very interesting statement in 1982, the American Academy of Pediatrics came out with a statement that said, do not use aspirin. It is inferential data, it is epidemiologic, we don't know why, but stop. And it's a fascinating position paper because it makes all the caveats that we think this might be important and Reye's is bad enough, let's try it. And so there was a huge transition in the care of children from analgesics and antipyretics using aspirin to using acetaminophen. To the point that, and it was a rather abrupt change, which was coincidental with this change in prevalence. And that's what began kind of the speculation that there may be a connection between the two. Now, this is fun stuff, in part to lead you up to, I'm going to lead you, okay? I'm going to sell you, and then I'm going to squash it. But I just want to let you know, this helps to give you some background. So, paracetamol is what they call it in Europe. It's acetaminophen. It was synthesized in the 1800s, and about 10 years later, it was first used as an antipyretic. And it's the principal metabolite of phenacetin, which gained a lot of play in the early 1900s up until about the 1950s and 60s. And phenacetin causes a lot of renal toxicity. And because of that, it lost favor, and in its place came acetaminophen. It inhibits cyclooxygenase 3, which is in the brain but not the lung, and works through the brain in terms of its antipyretic and its analgesic effects. And it's metabolized by the liver, which is why the primary reason for acute hepatic failure these days is acetaminophen overdose across the country. Most of those metabolites are pretty much harmless, and they're conjugated in a variety of ways, but about 5% of it is made into this particular substance called N-acetyl-P-benzoquinone. And this is an important metabolite because it is a very, very reactive substance which is deactivated by using reduced glutathione. And so through glutathione reductase, which has a variety of mutations we can talk about later if you like, this particular NAPQI is detoxified, but in so doing uses a lot of the antioxidant reservoir, if you like, to make you more likely to suffer from oxidation injury. Okay, so you're sunking up the antioxidants and you're left with less antioxidant defense than you might otherwise have. And this particular substance, acetaminophen, has been correlated with not only asthma, but with COPD and with respiratory infections and even pediatric lung function. So there's a lot of interest in the play of the oxidation business. Now, most of the oxidation discussions that go on in asthma have to do with pollution. So whether it's diesel exhaust or it's ozone, that's where people talk about oxidants. They don't talk about them on a day-to-day basis with pediatric asthma or respiratory infections, but clearly it's part of inflammation. And so here's where I start to hand wave a little bit. So people say, well, how does this work? And they say, well, it works on glutathione. Well, how much glutathione do you need to stay healthy? Well, we're not sure. Well, can you induce it? Well, you can. Well, how bad is this drug? Well, kind of bad. Well, how do you know? By epidemiology. So you can kind of see the dance beginning. I think what's really intriguing about, I'll talk about this in a minute, but one of the things that's really intriguing about this substance is that in mice at least, people have now found that this particular NAPQI reacts with a channel that's common in the non-adrenergic, non-cholinergic nerve endings of the lung, which is really interesting because now people are starting to say maybe this is starting to produce a neurogenic asthma rather than cholinergic, adrenergic, eosinophilic asthma. And that's just gotten published in the last couple of years. It hasn't been confirmed, but it starts to maybe broaden the discussion about the mechanisms by which acetaminophen may be playing a role in inflammatory diseases, such as asthma. The other thing that I think changed the pattern of use was in the 60s when aspirin intolerance and aspirin-induced asthma came up. So Samter wrote his article in 68, and the idea was that there are people who clearly get worse within 30 minutes to 3 hours after ingesting aspirin. And it really happens much more in adults than pediatrics. So the frequency with which you see aspirin sensitivity or NSAID sensitivity in children is like 2 to 4%. It's not a big player. And aspirin-sensitive asthma is a much more adult issue, and so we've kind of ignored that part. But it may have played a part in terms of the prescribing habits of people in general, and as they started to look at alternatives such as acetaminophen for antipyretics and anti-analgesics. This is some of the data, and I'm not going to show you a lot of this, but I'm going to show you kind of where people have gone with the glutathione story. So this is looking at both alveolar macrophages and type 2 pneumocytes in vitro, and this was simply a pharmacologic study using doses of, you can see here, 0.1 to 0.05 millimolar. That's about 7 micrograms per cc, and that's therapeutic ranges I'll show you usually are somewhat less than 10 micrograms per cc when you take a typical 325 or 600 milligram Tylenol dose. And so this is just a simple example of using a difference in dosing to show that intracellular glutathione is reduced as a result of acetaminophen exposure, more so in alveolar macrophages than in type 2 pneumocytes, which is here. And that tends to be time dependent, so the longer you incubate the drug with the cells, the more reduced glutathione you have intracellularly, suggesting that maybe that glutathione reduction exists and may play an important role in disease. That second part's a big inference. And this is the human study. I like this one because I don't know what serum antioxidant capacity is. In looking at this, you can see the pharmacokinetics of taking a gram of paracetamol. If I can get my arrow right here. So max dose, max serum level is at about an hour afterward, and you see it goes down by 3 to 4 hours. This is important because when you talk about effective acetaminophen, we're going to get into dose and effect as something that's not very well explored. And this was done in 2003, and I haven't seen a lot in terms of pharmacology since then. What's important about this is not just this. You can see first of all that your pharmacokinetics are the same whether you're taking this the first time or you're taking this 2 weeks later. But if you look at Trolox,
Fix that right now.
they're all off.
Sorry about that.
That's all right. So when you look at Trolox, and I'll tell you what that means, and I have no idea how they do it. It's a chemoluminescence study done on serum of people that's presumably testing the total antioxidant capacity of a human being. Now, don't ask me to explain that. I can't defend it. The methodology wasn't real clear. But if you look at how people, when they take this drug for day 1 and then for 2 weeks, and you look at the oxidation capacity, you see a small reduction at 1 day, but more importantly, if you take it over 2 weeks, you get an cumulative effect. Now this gets into the important question of how many days does it take to have toxicity from acetaminophen? How many days, how much drug, how often do you need to really get an effect that's going to explain asthma? I'm not going to answer that question, but this is about as good as the data as you're going to find in the literature on this stuff, which is not very good in vivo and in humans. So how often do we use acetaminophen? This really gets into some fun epidemiology. And it's probably time dependent, and it's probably culture dependent and economics dependent. And you can see that it's all over the board. But in general, when you look at the big studies, and there have been a lot of studies in pregnant women, we'll talk about that in a minute. You're talking about somewhere between 30 and 60% of the population is using acetaminophen. And Obstetrics has always suggested that acetaminophen is a safe antipyretic in terms of ductal closure and NSAIDs, and so there's a lot of it in terms of pregnancy. It's about a $1 billion industry in the United States right now, so this is over-the-counter stuff. It's not expensive, and it's still $1 billion. So a lot of people are using it a lot of time. The question is, why don't we all have bad asthma if that's the case? So I want you to look at a couple things. The ones that I think are most representative, you can see a big spectrum here. And I also want to suggest to you, if you look at these different ways in which I've described this is less than 1 day a week. This is one time at all. Here's one time per month. Here's one time in the first 6 months. So when you really start getting into the details of how acetaminophen is administered, you get descriptions all over the board. And so you really have to look at the frequency, and when people say, yes, I'm taking it, it's, well, how much and how often, and is it clustered, and all of that's poorly defined. This was one of the first, so the acetaminophen asthma connection was first described by Varner in 1998, after asthma had really taken off in terms of prevalence, and after that paper, people started to look epidemiologically, and this is the first meta-analysis I could find, which was in 2009 in Chest, trying to summarize what we know about acetaminophen and asthma. And there are a variety of outcomes, so I just want you to first think about this in terms of the way these are constructed. First, there are adult studies and there are children's studies. There are also prenatal studies. The outcome that people look at most often is asthma or wheezing. And so not always doctor-diagnosed asthma. A lot of this is the ISAC kind of questionnaire about wheezing. And so the real issue is then, what are you relating it to? And it's a lot of apples and oranges in terms of what the outcome is. Then there's really, do you use high dose or low dose? And then do you use in the first year of life, the first 3 years of life, prenatally? And all of those things then have been done epidemiologically to try and find associations. And the interesting thing about the literature is that if you look at these pooled odds ratios, for the most part, they're all between about 1 and 3, usually about 1.6 as an odds ratio. So there's some signal there. And the confidence intervals are all statistically significant. So when you look at this, you can count the studies up, and you've got this in your handout, so I don't want to belabor the point. But what's important here is that people are starting to sniff around this topic and say, what is this? What is this? And they're not doing it in a very organized fashion, but the numbers are starting to be more compelling, that there may be a story here in terms of the relationship between acetaminophen and asthma, both in adults and kids, and also in terms of prenatal exposure and whether or not that influences pediatric outcomes. This is a good example. This is from the ISAC International Study Phase 3, and I put this on here because it encompasses about 36 countries worth of data. And this is a fairly typical kind of publication, and I'm using this as an illustration both to acknowledge it and bash it a little bit. The question was, if you take kids 6 to 7 years old, any one of these centers that happens to participate in ISAC needs a minimum of 1,000 respondents. And they have to have more than 85% of all the surveys filled out in that 1,000 to get included in this kind of study. We've done this in Seattle Public Schools. And as part of the ISAC Phase 3, which was the follow-up to the Phase 1 and looking at temporal changes in asthma prevalence throughout the world, they added a supplemental survey, which was one that included a variety of questions about environmental exposures. And one of those was acetaminophen. Now, to give you the construct of this kind of study, you have 6 to 7 year olds whose parents are given a survey to say, does your kid have rhinoconjunctivitis symptoms, eczema symptoms, or asthma symptoms? And the question that people always use in the asthma symptom, at least that they correlate with asthma, is have you wheezed in the last 12 months? Have you wheezed once in the last 12 months? If that's yes, then you have asthma. Now that's in 6 to 7 year olds, I don't know, you can take it or leave it. They've been pretty upfront about their definitions. But what they did in their environmental survey is they asked 3 questions. Did your child receive acetaminophen in the first year of life? Now that assumes you've got great 6 to 7 year recall, number 1. Okay, so there's a problem there. But if that, then has your child received acetaminophen in the last year, at least once? And if that, has your child received acetaminophen in the last month? So those 3 questions were the ones that were asked on this. And this one happens to be exposure in, I think, the last year. And it turned out that if you looked if the first year of life, the odds ratio was like 1.3. If you looked at then in the last year, it was 1.8. And if you looked in the last month, it was 3.2. So a 3-fold risk of having wheezing in the last year if you took acetaminophen in the last month. Now there's huge inferences there. You could have wheezed 6 months ago and taken an antipyretic 3 days ago, and it'd be hard pressed to say there's a relationship. Okay, so realize that these are simply associations. And the important point of this is the magnitude with which everybody's saying yes. So in acetaminophen, when you say acetaminophen in the last year and you look across these countries with 180,000 kids and you look for odds ratios, you can see they're across the board. But there's a kind of a funnel there around 1.5 to 2.5. So around 2, saying about twice the likelihood of wheezing in the last year if you've had exposure to acetaminophen in the last year. Now you can buy this or not. I'm not trying to sell these studies, okay? I can sell encyclopedias, but I'm not going to sell this. Okay, what I'm going to tell you is this is what's generating the interest. And that's an important kind of, and there are lots of studies like this. So this is just one of the biggest and most often quoted, which I think is why it's so illustrated. Now, to their credit, and most of these are very, very good epidemiologic centers, and so these are just some of the confounding. I could have doubled this slide, but I'm looking at the confounding factors to which you have to adjust to get those odds ratios. Not every study uses this entire list. Everyone uses at least 5 of these and sometimes 50 of these as covariates in trying to establish odds ratios. And you can see that they're ones that we all know about. There's some that are really interesting, like gang warfare in neighborhoods, sleepless nights of mom's depression. There are a lot of them here that people have looked into, and not everybody uses all of them, but everybody is trying to address confounders. So it's not simplistic research. I don't want to give you that impression. This is pretty good epidemiology, and again, they're searching for inference here, not cause and effect. The next kind of group of studies that people have looked at have to do with cohort studies. And cohort studies are enrolling pregnant women and then following kids for a period of time thereafter to look at outcomes that may suggest airway disease and perhaps asthma. And this is an example of this. It's a pretty good study, at least in terms of being illustrative of what's in the literature. So this was a Columbia Center children's study done for a period of 8 years. During that time, they enrolled 1,400 moms. All of them had to be non-smoking. They had cotinine levels in the urine on everybody to ascertain whether they were smokers or not. And as a result, they didn't get quite as many people enrolled as they thought they would. But during that 3rd trimester, they asked the moms, have you used in the last trimester? So that's a long period of time. Have you used NSAIDs or have you used acetaminophen? And this is fairly representative. So about 34% of people said they'd used acetaminophen, 3% said they'd used ibuprofen, and 1% said they'd used aspirin. So this is kind of human behavior, pharmacologic behavior in pregnant ladies. And so, and this was done in New York. And out of that 1,442 that were enrolled, that were non-smokers, eventually 700 of those kids were enrolled at birth. They were followed at 6 months and 1 year and 2 years and 5 years, with the idea that if you were wheezing by the time you were 5 years of age, you must have asthma. Okay, so that's the inference. And the primary endpoint was that whether you're 1 year or 2 year or 5 years, that if you wheezed, you can hear Isaac in here, if you wheezed in the last 12 months at 5 years of age, and that was the endpoint to see whether or not you had a relationship between acetaminophen and clinical diagnosis of wheezing at 5 or maybe asthma. And over that period of time, and importantly, I think just for methodology, is that they had a hard time keeping these people in the study. So by 5 years, you're really only talking about 300 kids instead of 700 kids, which obviously influences how you do the statistics, and then there's a high dropout rate. With that acknowledgement, if you looked at wheezing patterns over time, this is true of general pediatrics, that 40% of the kids wheezed in the first year. Okay, this is regardless of whether or not moms took acetaminophen or not. So just in the prenatal enrollment and subsequent follow-up, 40% of the kids wheezed in the first year, 25% wheezed in the second year, and 27% wheezed at age 5 years. So we know with bronchiolitis and all the rest that kids stop wheezing in the first 3 years, and 2/3 don't wheeze by the time they're 5, and this is just a general pattern. It's not surprising. Now I show you this because as wheezing was going down in frequency, the relative adjusted risk of wheezing in the last year and those people with acetaminophen was going up. So if you had had acetaminophen in the 3rd trimester and you looked at the adjusted with all those other variables we talked about, the relative risk of wheezing at a year, 2 years, 3 years, or 5 years, you can see that when wheezing was going down, the risk of wheezing adjusted for acetaminophen use was going up. Well, this is kind of interesting. And it begs a lot of questions, but it doesn't really say there's cause and effect. This is an association. And the question then becomes, why might these be associated? And the obvious answer is that, well, gosh, kids get sick. They go to preschool, they get fevers, you give them acetaminophen. If you keep wheezing, if you don't, big deal. And yet if that's the case, wheezing was going down in the general population while risk was going up. And that slows down that kind of argument a little bit. Now, this I think is part of why I'm not happy with this current degree of this literature. And it has to do with outcomes. It has to do with how do you describe acetaminophen effect. And so we have days of treatment. We have patterns of use. Do you use it more in the wintertime when you get colds? What's the milligram per dose? Or do we talk about cumulative milligrams received? And if so, over what period of time? Is it days or weeks? Is the timing important? There's a lot of assumption that if you take something in the prenatal period, and there's been a lot of discussion about timing in the 1st, 2nd, or 3rd trimester, and the results are all over the board. If I had to give you the net positives, it's somewhere in the 2nd and 3rd trimester where this might have an effect compared to the 1st, but that's a lot of time. And the assumption that you should take acetaminophen twice in a month and have profound effects subsequently on a 5-year-old is pretty profound. And it's difficult to implicate glutathione reserves as a mechanism for that long-lasting effect. Now, that's thrown stones at this, and at the same time, I want you to think about the idea that's kind of percolating, is that oxygen, let's just say oxygen, maybe it's the nerve endings, I don't know, but that this drug, or the metabolites of this drug, may have long-lasting effects in ways we don't understand as yet. And if that's the case, is there a window of susceptibility where you start to change your prescriptive patterns in terms of risk of subsequent lung disease on children whose moms are pregnant and have fevers or pain? So there are variations in whether you look at the first year of life, whether you looked at the first year versus the last year. I've illustrated those. And whether people had diagnosis of asthma in the first place. So a lot of these people didn't really assess for the confounders of eczema or maternal asthma, for example. The outcomes are different. How do you class the diagnosis? There's actually one study that looks at does exhaled nitric oxide and bronchial hyperreactivity and spirometry at 5 years of age, and tries to associate acetaminophen use prenatally with abnormal lung function. And there are these 2 studies out there on this. And then the question is, what's the endpoint? And do you influence somebody equally at 6 months of age compared to 10 years of age? And if so, how do you explain that? There are differences in terms of drug effect. And I'm going to show you what I'm going from crappy studies to better studies so that I convince you to go home thinking about this, okay? And I'm going to show you the better studies in a minute. But one of them has to do with incident asthma as opposed to prevalence of asthma. And there's another study I'm going to tell you about, which is an intriguing one that talks about worse asthma control. Not incident asthma, not prevalence of asthma, but actual symptoms of asthma that require medical attention. So, and nobody talks about change in the requirement to change asthma therapy as a result of this exposure. So just realize there are a lot of vagaries to this methodology. And as much as I'm kind of bringing up the topic, I don't want you, by virtue of these epidemiologic studies, to go home and change your practice. Now that said, I'd like to tell you about some of the ones that I think are actually interesting studies. There are 2. This is the first one that was done. It's a national health study done for 20 years. It was done in women. There were 120,000 people who enrolled between 35 and 55 years of age in the 70s. And over that 20-year period of time, they're really interested in heart disease and lifestyle and smoking, yada, yada. And it was only in 1990 and 1988 that they started to inquire about the diagnosis of asthma. And they started to inquire about the exposure to acetaminophen in 1990 and 1992. And what they did in this study was to look at incident asthma, not past history. So they took out all the women who had a past history of asthma from 1988 to 1990, threw them out, and then looked at the rest and said, okay, so can we inquire about acetaminophen use in 1990 and 1992 and look at what happens in terms of incident asthma over the next 6 years? And the endpoint was doctor diagnosis free. This is relatively rigorous for these kinds of studies. Doctor diagnosed asthma plus the use of an asthma controller in the last year. Not albuterol, but an asthma controller. So you go, okay, well, all right. That's good enough for government work. Let's use that as an endpoint. The acetaminophen usage, you can see this, is not milligrams per kilogram, but 0 to greater than 15 days a month. So at least frequency. Not dosage, but frequency. And who knows how many months they asked for, because they just said, how have you done this in the last month? And they did this on their surveys. The surveys come out twice a year. So you're looking at 2 measurement points between 1990 and 1992. Now, one of the really interesting things about this data was that if you looked at 1990 and 1992 in this big population, the frequency of acetaminophen use was about the same in both years. And when you looked at the crossover in terms of people using a lot going to a little or a little going to a lot, it was only 3%. So it's kind of like people are used to taking these drugs based on their philosophical approach to life and whether or not they tolerate pain or fever, because the users in 1990 were pretty much the users in 1992, which was in some ways very comforting in terms of trying to look at the incidence of asthma over 6 years. Over that time, they had almost 10,000 cases of asthma diagnosed, and these, at this point, getting to be elderly women. If you look at the relationship, the rate ratio, this is intriguing. So if you look at that use of acetaminophen in 1990 and 1992, but primarily 1990 because that's when they start following it, and you look at the frequency of use per month, assuming all months are the same, what you find is that incident asthma increased as a risk the more acetaminophen you took. Okay, now this is incident asthma. This is in past history. Can you remember? There is some memory here, but primarily this is ongoing surveys to look at the onset of new diagnosis requiring controller meds. And here you start to pause a little bit. Go, how do I blow this one off? This is interesting because I can't make a pre-ascertained bias here by this study design. And so I think this starts to make the question more interesting rather than simply inferential.
Maybe the people are treating their asthma with acetaminophen.
Or avoiding aspirin.
Well, you know, they think they're sick. And so they're
Yeah, they could be. So let's go to my favorite of these studies. And my favorite of these studies is done in Boston. It's done in kids. And it is the study of fever. And historically, this is the fun part of this. In the early 1990s, when asthma was becoming more prevalent, the basic bias of the investigators who did this study was that ibuprofen was going to make asthma worse. And so ironically, they used acetaminophen as their control group, their placebo group. Okay, and they were expecting there to be a dose response for adverse asthma outcomes based on the dose of ibuprofen given for fever. Now in this study, there were a lot of kids enrolled, 84,000 kids were enrolled. And this study got a lot of play looking at safety of ibuprofen. So frequency of GI bleeding, frequency of renal toxicity. There are a lot of papers by this group in terms of the risk of ibuprofen in the immediate post-1993 era when they were publishing these studies. And it wasn't until after 1998 when people started to think about acetaminophen and asthma that they went back to this database. And they said, well, let's just take this group and see how many had asthma. All right, and if they had asthma, what was the effect short-term over 4 weeks of children who were encountered with fever? And again, the study design was that if you came in with a fever somewhere between 6 months and 12 years of age, and I think the average was about 4 years of age, but if you came in with a fever and you enrolled in the study, you got X drug. This was placebo. It wasn't placebo control, but it was randomized control in such a way that you either got acetaminophen or you got ibuprofen. You were randomized to this in 2 doses of ibuprofen. And it turned out that the proportions of children with asthma who received these different drugs was pretty equal. And again, the diagnosis of asthma was whether or not you were taking an asthma medication the day before you were encountered. Now that's pretty potent. So if you came in with a fever and you had been taking asthma medicines, including albuterol, the day before you enrolled in the study when you got your fever, then you were enrolled in the study and you were called an asthmatic. So that was their definition. At least it's not a doctor diagnosis. It's not wheezing. Somebody's actually taken drugs to make this diagnosis. So with that kind of definition in mind, they looked at the relative effects of these on asthma control. And this is, I think, kind of interesting stuff. So if you look, they looked at hospitalizations, and hospitalizations were insufficient in number to really have any statistical bearing on the different groups. But they looked at the outpatient visits for asthma in the 4 weeks following the enrollment. Again, looking at safety. You can see the numbers here. I'll put them up here. This is in the Pediatric. It's a 2002 study, but it's the one that everybody quotes, which is to say, you know, how if your adjusted risk for acetaminophen, presuming it's the placebo here, the safe one, is 1.0, then what's the risk of taking ibuprofen and seeing a doctor for asthma in the subsequent 4 weeks when you get the fever? And it's 0.56. Now, these guys also did a very interesting part of this that a lot of people haven't done, which is to say, why did you go to see the doctor in the first place? And that had to do with upper respiratory tract infections. It was all infection. So one of the sidebars to this whole comment is, you know, do you take your Tylenol because you have pain or because you have fever? And very few people distinguish that. This was a study about fever and not pain in children, number one. Number two, they were able to identify the reasons why you were seeing that initial enrollment encounter. And the vast majority were respiratory infections, and most of them were upper respiratory compared to lower respiratory tract infections. But there was a good number in both groups, and I neglected to put this up as a table. But in looking at that, if you looked at acetaminophen versus ibuprofen for colds, sinusitis, pharyngitis, otitis, there was no difference in terms of going to the doctor in the next 4 weeks for asthma among these asthmatics. If you looked at lower respiratory tract infection, actually the odds ratio was more dramatic because when acetaminophen was 1 as the reference point, ibuprofen was 0.41 for an odds ratio and statistically significant. So now you're not only saying, well, I don't know why you went, but it's probably a fever and the virus caused your asthma in the first place, so it wasn't the drug. So, you know, you were talking about the wrong causation. Well, all of these kids actually had their diagnosis identified in the fever study. And it turned out it was only in the kids with lower respiratory tract infections where you saw the greatest difference between acetaminophen and ibuprofen, with an odds ratio of 0.4. So it's a substantial reduction in requirement for care in the 4 weeks after you come in with a fever, knowing you have asthma, when you're given either one of these antipyretics. And if one looks at the dose relationship, again, remember, this was a study where people were interested in the toxicity of ibuprofen. And the cumulative dose in this was, people were allowed to give acetaminophen or ibuprofen for multiple days if the child had multiple days of fever after they were enrolled. So there's a cumulative dose that people were looking at. How much total did you take this drug during the time that you were sick in that last 4 weeks? And you can see the breakdown here. Part of this was by design because there was high and low dose ibuprofen. Part of it was not by design, and that was the acetaminophen dosage differences. And you can see with ibuprofen, whether you were on low dose or you were on high dose, the risk, the cumulative index of having to have follow-up in the outpatient for an asthma problem was 3% for the ibuprofen. It was 4% for acetaminophen, but when you took more acetaminophen, it was 6%. Now, this is not cause and effect, but this was not done, this study was not done to look at the dose effect of acetaminophen on asthma symptoms during acute exacerbations. So this study was done for the wrong reasons in terms of why we're talking about it today, but it has a very interesting database and implications, not in terms of incident asthma, not in terms of asthma prevalence, but in terms of asthma difficulties during that illness that prompted medical care. And I'm going to leave you with this one because this is the way everybody will talk about. It must be at least 30 studies now as I've described to you in the first kind of studies, either a cross-sectional study with retroactive recall and associations with acetaminophen and wheezing in different age groups, or cohort studies that are nonetheless still inferential because there's not a specific dose, there's not a specific follow-up, there's just general kind of, is there a connection sometime throughout your life, the rest of your life after your mama takes acetaminophen. So those are, I think, relatively weak. When you look at the studies about incident asthma, it's a little harder to say there's a preconceived bias. And in this kind of study, where you're not really asking the question at the time of the study, but it's a convenient sample that allows you to ask the question about acetaminophen, it's intriguing that there are actual statistical differences, and there may be real differences. So this is the one I want you to explain away. Okay, this is the one I want you to say, nah, there's no relationship at all. So here's what Steve Holgate says about all this. And I've given you pretty much my take on the literature. It says, there's now overwhelming evidence establishing a link between acetaminophen and asthma. But despite one trial of acetaminophen versus ibuprofen and respiratory fever, it's the one I just showed you, reporting a difference in favor of the increases in asthma in the acetaminophen arm, the absence of a placebo precludes determining whether or not there's a difference was due to reduced asthma and ibuprofen. So does ibuprofen reduce your asthma risk, or does acetaminophen increase your asthma risk? Interesting question. Turns out there's two prospective studies that I looked at about this. One was using aspirin, one was using ibuprofen, and that national women's study I showed you that looked over 6 years, when they looked at the use of aspirin for X number of times per month over a 6-year period, the risk of subsequent asthma, or incident asthma, was 0.4. So there actually is some data that suggests that regular use of aspirin might actually reduce your incident asthma risk. Now that has all of the epidemiology that you have to decide whether you buy into or not, but there's a little bit of data out there. This was done in a cardiovascular study looking at vitamin E versus aspirin for a long period of time in women, assuming they would get cardiovascular disease, but they also looked at asthma outcomes. And they found a reduced risk of incident asthma in people who took aspirin long term for heart disease. Now, you can believe that or not, I'm just throwing it out there, but in terms of Holgate's statement, what he was really asking, is this all acetaminophen, and let's not get into the mechanisms of glutathione, but is this because acetaminophen increases your risk, or is this because alternative NSAIDs or cyclooxygenase inhibitors may reduce your risk? And he just left it at that. This was an editorial, and so it was meant to be provocative. This is the initial paper, and if you'd like to read a well-thought-out provocation, it's in Pediatrics last year. It says, in my opinion, the balance between the likely... John McBride's a friend of mine. He's a department chairman in Dayton, Ohio, and he's trained in Boston, Pediatric Pulmonary, so I've known him for a long time. He's a well-considered guy. He's not screwball. And he writes, in my opinion, the balance between the likely risks and benefits of acetaminophen has shifted for children with a history or family history of asthma. I will recommend avoidance of acetaminophen by all children with asthma and those at risk for asthma, and make parents and providers aware of the possibility that acetaminophen is detrimental to children with asthma. Now, I'm going to leave it at that and just open it up for discussion, because I think it's not a hot topic, it's a percolating topic. It's a persistent topic. And it is starting to get play, particularly in general pediatrics, as people hear about this relationship and they read this kind of, this is not an editorial book, it's an editorial book, it's a full article, it's a kind of a literature review, some of which I've covered for you, to try and raise the red flag that there may be a relationship here. And if there is, how are people changing their patterns of care? And what are you going to do about it? Let's get the lights on.
Great.
So I hope you like it. That's fun. It's a fun topic.
Let me ask you a somewhat tangential question.
Go ahead.
I've always considered this drug no better than placebo as an antipyretic and anti-inflammatory. Backing up, is there any data that the drug is better than placebo independent of this question?
Yes, there is.
That it's
As a matter of fact, there's good data. Well, the data is, both in terms of how many people have reduced fever as a result of it, and then over time, how many have sustained reduced fever. And it turns out there is data on that, and there's also data on the typical pediatric practice where you give one drug, and then if your kid still has a fever 4 hours later, you give another drug. So you give ibuprofen, and then you give acetaminophen, or you give acetaminophen, and then you give ibuprofen. And there's data on that. You reduce the fever instead of 80% of kids still having persistent fever. I think, no, I'm going to screw this up, but I think it was like 20% still had fever at 8 hours with a single drug. 50% had a persistent fever with a single drug, and if you alternated drugs, it was down to 20%. So there is actual data on the relative efficacy of antipyretics in kids. Steve?
So one thing that is interesting, I mean, back in the day when asthma wasn't as common, we were all taking aspirin growing up. And then I think presumably the idea with acetaminophen was it was safer, right? It had better therapeutic index. Now that's come into question. They're changing the maximum 24-hour dose just to reduce issues. And with this data that's sort of there but not proven as cause-effect, I mean, to me the question is, why wouldn't you use ibuprofen? If we're staying below the danger doses, is the therapeutic index of that independent of asthma? Is the therapeutic index of ibuprofen inferior to acetaminophen? Because I think it's a much better feel-good drug and fever drug.
Well, you know, I don't know if you saw the first slide when you came in, but we talked about Rye syndrome.
Yeah.
And in 1982 is when people said, you know, aspirin will kill you if you take it with influenza and you get Rye syndrome. So there was a very discrete point in time where the American Academy of Pediatrics had stopped using aspirin in kids.
And ibuprofen does not have that same risk, is that right?
Right. I mean, you got to remember in '82 they were trying to look at what the hell was causing this. So I don't think people looked at ibuprofen to even ask the question.
Right. I mean, that's a cultural and historical bias, right?
Yes.
And so, I mean, I remember when, you know, ibuprofen came out, it was prescription only. And sort of like a meprazole. I mean, it looked like
well, and there had been a history with phenacetin of renal toxicity. So people were sensitized to the risk of NSAIDs as causing not respiratory disease, or good or bad, but of causing renal disease. Okay, and it's only recently, now we're swinging the other way to acetaminophen, now it's causing so much hepatic disease. It drops the dose. So you're seeing historical trends in part. Yeah.
Just a comment to Steve's, is there's some considerable evidence now that ibuprofen is not the best of the non-steroidals in adults. And there's some recommendations to not use that drug at all in adults for other reasons in terms of cardiac protection.
Oh, in terms of COX-2s?
Just basically, people take ibuprofen thinking they're cardiac protected, and they're not. So basically, they're showing up with more disease than people who don't take ibuprofen compared to aspirin, and the other non-steroidals. So this drug is falling into disfavor in adults too.
I mean, I think that's true of all non-aspirin. They all have a.
But the ones with the longer half-life don't have the same statistical problems as this one with the 4-hour half-life, which is what getting people in trouble.
But don't you think the cardio protection, though, if you're taking baby aspirin, then you can just stack the ibuprofen on top of that? And
if you take enough, but the half-life's so short, the problem is you don't get 24 hours of protection with ibuprofen, you get like 8. And with aspirin, it's until the platelets are dead, so it's 10 days. So there's not an overlap of symptoms for cardiac protection.
Right, but if you're taking, maybe I'm missing the point, but if you're taking aspirin anyway every day.
But these are people who aren't taking aspirin.
Right. But if you're taking aspirin for a totally different reason,
I don't think
because it's a cheap way to stay alive, and then you use your ibuprofen when you get fever and pain or whatever. I mean, isn't that rational?
You're killing yourself with ibuprofen, and you can bring yourself alive with aspirin.
Something, right?
But I just wondered if anybody's looked at the other.
What are you recommending to pregnant women with asthma in terms of an analgesic antiproton? I don't take care of that. Yeah.
Two quick questions about the literature. Is there any literature of the conflicting opinion saying that aspirin or acetaminophen is not causing this, or the negative studies out there?
No.
Or are people not publishing it because
I don't know.
They don't want to publish?
I don't know that one.
There is a very small study done by David Hill's group about 2 or 3 years ago, and he was part of Isaac, I think, initially. And what they looked at was and again, it was about 600 kids, mind you, not 80,000. But they attempted to factor out the frequency of infection, started dividing that, and things start melting away when you do that. They also didn't see any dose relationship, although then it begs the question, well, what's the pathophysiology? Is it the glutathione, or is there some low dose non-adrenergic thing where the dose doesn't matter? So it didn't really answer that. And then they also looked at, well, what about non-respiratory infection use of acetaminophen? And again, it went away. But again, you're not giving the drug when you're getting, potential risk for asthma. So it still didn't answer the question. But
I think most of that literature is kind of trashy.
Yeah.
Okay, there's a lot of inference, and the vagaries are overwhelming if you start to try and answer this in a specific way. Or if you have a conceptual model. So, do you have a window of opportunity or a window of vulnerability where the drug might do something to the fetus, subsequently dictating lung function or inflammation or whatever? And those concepts are used in the discussion section after they've looked for inference rather than a priori looking at a concept and pathogenesis. So I think it's kind of a lot of trash.
Well, you're right. You make inferences to almost justify.
But there's
your
a
outcome.
lot of trash out there. I mean, this is a hot topic prompting a lot of editorials, and you have to really look for where are the pieces. So I like the Boston fever study, and I think if you can attack that successfully, you can attack the concept. But that's not an incident asthma question. That's not a prevalent. Did this make your asthma worse? And there are studies looking at ibuprofen. I haven't seen any I've seen one study on acetaminophen, I think, looking at airway response to inhaled adenosine. So an immediate response in over a period of 4 hours, peak effect. And there's no difference. And this was placebo-controlled, real small study, about 30 kids, but they came back for either placebo versus. So there's no immediate change in lung function now. Does that mean there's a change in inflammation? Nobody's looking. So you can see where we are in terms of the questions here. Yeah.
Has anybody looked at the adults that are acetaminophen sensitive asthmatics to see if they share any of the same correlates with the kids?
Well, no, because the kids are all population studies. I mean, they're not individual studies to look at cases and then further describe that particular kind of person.
So I've always been confused at that group of asthmatics that are supposedly acetaminophen sensitive asthmatics. And it's a really small subset, but it's obviously maybe linked into the same processing of the acetaminophen.
You'd think with the amount of acetaminophen being used in the general population that this would become a big-time issue. And right now it's kind of subterranean, subcult stuff. But it's hitting, the reason I bring it up, because I think it's worthy of discussion, is because this is hitting the general peds literature in a very strong way with very strong biases that I'm not sure are warranted, but at the same time you're going to have to deal with.
What do you do?
Yeah.
Right now,
what are you doing over at children?
I think the boss, we're reducing the dose of acetaminophen for liver disease. So, that's what's happened. But nobody has said, I mean, this paper's been talked about a lot. We did this for Journal Club, and everybody scratched their head and said, well, is there strong enough evidence based on the Boston fever study to say, no, we'd rather you take ibuprofen instead. Let's ignore all the rest of the epidemiology. That's kind of fun, conceptual, maybe. But look at the Boston fever study. It's a really interesting study because you have to decide, is it just luck? Is it just bad luck for 1,800 kids? Or is there something there? And nobody's replicated that study, which is what really needs to be done. I will tell you that the NIH is working right now on it. There is a project ongoing. As I'm on the DSMB, I can say this. There is a multi-center project right now looking at exacerbations of asthma in kids 1 to 4 and randomizing them to either acetaminophen or to ibuprofen. So that study is ongoing. It's been really slow to enroll. I'm not sure they're going to get enough kids to to make some real strong conclusions, but it's being funded by the NIH with the AsthmaNet research group. And I think, 12 or 14 centers to actually try and answer the question. So realize that if they can ever get it done, we'll actually maybe have some better data.
Any animal studies?
Yeah, but not.
I mean, granted, then it's.
I don't know an asthma. I don't know an asthma model where anybody's ever looked at this. You know, there are pharmacokinetic studies, and there's this interesting in vivo study on nerve responses and nerve channels. But that's a single pharmacology study.
Are there differences in metabolism between people that are slow, rapid metabolizing?
It's a great question. I don't know. Because, everybody says, well, the bad actors is 5%. And so that seems like a small amount. So exactly how big is this? And if you were to metabolize 90% of acetaminophen to this, would you have a different response? So, great question.
Yeah.
Or looking at kids who have overdosed and then looked at subsequent pulmonary.
Great question. Good idea.
That's
Really bad asthma in those kids. No, I'm kidding.
and back in the Boston study that you mentioned, high dose, low dose, did they look at the cumulative question?
Well, that was
in other words, low dose times 5 versus high dose times 2.
Well, remember the study was done, so you had low and high dose ibuprofen were given per dose. And then what they looked at was cumulative dose in that 4-week period. So if you had a 2-week illness and 2 weeks of fever, you took a lot of drug. No matter what dose I gave you per pill, you took a lot of drug. So they portrayed this, cleverly or otherwise, as cumulative dose during that time. Yes?
Do you see a day when kids will take aspirin again?
No. I mean, you get aspirin with valvular disease and heart disease, so we do have a subpopulation. We haven't seen rise in a long time.
I wonder about that.
Yeah, we just haven't seen it. And we have enough kids on aspirin, for rheumatologic disease and heart disease, so there are populations that still take aspirin. We just haven't seen the rise. We haven't seen the case of rise in about 20 years.
That's why I asked.
Those kids, do they get it? The rheumatologic kids?
They don't. I don't think they do.
I haven't seen it. I haven't seen it.
And the reason I asked,
that's a fascinating study. That paper is fascinating because it says we don't have the data, but here's our concern, and it's so bad. Let's do something about it. And it just rise went away.
This sounds like a really good reason to give kids steroids when they have respiratory illnesses instead of any of these.
The prevalence of things like kernicterus and other evils of the past just aren't there.
I agree.
And so, do we take it as an article of faith that aspirin is necessarily bad, or is?
Well, as we old farts go on to retirement, and you guys start using more aspirin, you may see it come back. All right, thanks very much.
All right, let's take a momentary break and David's going to present a case.
Make a little prayer on that.
Yeah, he did. And it was a great first time. Regis McFadden used to say that when he ever talked at the academy. He was actually really important.
What did he talk about that?
Anything. They asked him to talk about
You're from Cleveland. Cincinnati. It's from the Midwest somewhere.
but it could have been. It was in the Midwest. That sure makes me want to give steroids to all those kids now that come in and give everything. I think Pediatric sounds like a better. I have.
I can believe what you're about. So I appreciate that. Everyone has to wonder where there's genetic strains. Bacteria was the common industry. What is it about these diseases that are more prevalent there? For example, I use the right, so I like it. Obviously, people use that. Even exchange transfusions and more emergency measures. The threat is there, but anyway, I'm just wondering out loud if it was sort of like two things happening, and ask what happened. Sure. Yeah, varicella out there. We should get a little susceptibility there.
That's what I've always thought. We need to have some kind of go. So, sorry. If we can Yeah, I was gone for the weekend, so I could take it back.
Historically, aspirin was a longer format. It's something immunologically that aspirin is set on.
Dr. Brookmiller. He's from
I'm
Dallas.
very sure as well.
Oh,
From
But you know, but
so he's actually
aspirin
another rep who's actually on, it's on the quad AI. He was like, guys, and obviously he's autistic.
one thing I know.
For you guys for emails, because he wanted maybe to rep to reach out to you. What are your things from
Sometimes I wonder why I see a business over the counter. I really.
Well, yeah, let me look at that.
The rep was like, I should have asked about all my stuff now.
There you
So,
go.
all the yeah. I was like,
You can't get it through Civic, I mean, I'll give it to you.
okay.
But yeah, I know Brett.
Because he was like, I just went to Seattle.
You know, they used to call them family terrorists because they would take their aspirin.
She can if she wants to get
And they knew they would go in.
I know exactly.
So, yeah. But if you can get to him, get him the out of it.
Oh, wait, what am I?
Yeah, he said it.
Which is not necessarily saying.
Yeah, see, if you're I would think just in the next 3 months,
Start Tuesday. Well, thanks. I'm glad we're done. Yeah, I'm glad we're done. No, we're also talking about
Oh, right, yes, no, well, there you go. The meeting I had,
yeah, Paul is the editor.
right, and then
I was going to see when you got
really strong. Oh, good. We're working with the guy that
oh, I really,
I love. We're getting a new person. But yeah,
oh, good.
Awesome day. I'm hoping think about that.
Yeah, like.
I'll probably look for
Retrospective.
You want an LC? Yeah, I would want to divide it by one course.
You're just
I call it
and almost none. The difference, there's actually a difference in grade point average. It's like, I mean, they're all good students, but So that'll be interesting. And then we did I got to bring in 20 competitive. Well, no symptoms.
That's my call your guy, or?
Yeah. And I pulled random.
Oh, right.
Oh, and by the way, it's
Okay.
you guys.
Yeah, I got it.
Just huge.
His office manager had a good point.
And in terms of at least my discussion as far as the way of asking a person anxiety question.
If I especially maybe I'll get a hold of it.
And I think
I'll get hold of it.
I think that's the east side upper middle just getting to college. Harvard. It's not necessarily only those people who get or the VCD isn't necessarily the natural. And actually, Drew helped me so that
Let's go ahead and sit down, everybody, and
40%.
let David present a case.
There you go.
All right, I got it.
Okay, see ya.
Thank you for this. That's more important to do. So I would like to present a case of a girl who was recently seen at the neck. This is a 9-year-old girl with history of recurrent asthma exacerbation, who was referred for evaluation and recommendation regarding management. So she was first diagnosed with asthma at 1 year of age. She had recurrent ER visit and one admission to the pediatric ICU for severe asthma when she was 5 years old. She was not intubated at that time. Since then, she had recurrent ER visits or admissions due to asthma exacerbation around 5 times a year. She mostly has exacerbation with URIs, but also has mild symptoms with exercise. Her symptoms include cough, chest tightness, wheezing, and shortness of breath. It usually starts with a wheezy cough and can rapidly progress to more severe respiratory distress. She also has a history of frequent sneezing, rhinorrhea, and postnasal drip, and also has a history of eczema, which was not active now. She does not have history of recurrent infections, pneumonia, or ear infections. I had access to the Seattle Children record, so one typical exacerbation can describe one typical exacerbation. So it started at the end of last December. It started with a fever up to 39 and cough. The fever resolved after 2 days. The next day she developed more severe cough, wheeze, and also post-acid mesis. She first went to an urgent care clinic and was started on 5 days of prednisone. But even during these 5 days, she required albuterol, either inhaler or nebulized albuterol every 4 hours. She would improve for a couple of hours and then will require the next dose of albuterol. And finally, 5 days later, she was referred to the ER. Maybe she just liked the date of 12/12/12. At the ER, she was pretty stable, respiratory rate of 22, heart rate of 102, and O2 saturation of 100% in room air. She was not in any apparent distress, and on physical exam, she had normal chest shape, minimal retractions, and some respiratory wheeze with diminished breath sounds on bilateral basis. She was treated with albuterol, ipratropium, dexamethasone, and after an hour or two, she was discharged. They gave her another dose of dexamethasone the following day, and she improved after that. Her current treatment is albuterol as needed, and she's using nebulized albuterol and ipratropium with more severe symptoms. The year before, she was put on fluticasone 110 BID during the whole winter and fall during the URI season, and she still had the same number of ER visits. Montelukast was tried in the past, but she developed hallucination with febrile illnesses, and it was discontinued. And when she was seen at the neck, she was off treatment for 2 weeks. She has family history of asthma. Both her parents had asthma. Also has family history of allergic rhinitis and eczema. She lives with her mother and stepfather. She also has a younger sister. They have 1 cat at home. She spends a lot of time at her grandmother's house, who has 2 dogs and a large bird. And the grandmother is a smoker. On physical examination, she was mildly obese with a BMI of 27.7. lungs were clear, and she didn't have any active eczema. Skin tests were negative, but intradermals were positive to cat, dog, and feather mix. She was tested negative to dust mite. She had basically normal spirometry when she was seen. So you can see the curve, FEV1 of 100% and a ratio of 93%. So in summary, this is a 9-year-old girl with recurrent severe asthma exacerbations, mostly triggered by URIs, and on many cases she'll end up at the emergency department. She suffered exacerbation despite treatment with fluticasone. She has normal spirometry between episodes. IDs were positive to cat, dog, and birds which she was exposed to, and she's also a secondhand smoker. And the questions that I can think about, and there are many other questions, how would you treat her now when she's okay now, but you want to prevent the next exacerbation? What can we say about the natural history of her disease? And also, would you recommend getting rid of the cat, dog, bird, or at least some person who has the most of them?
Leave those questions up.
Well, if I see a case like this, the first thing I always think is this really run-of-the-mill asthma, or is there something more? So, I mean, how much other workup was done? I always think about the asthma sort of plus things and the sort of asthma mimickers. So do we have chest imaging?
No, we don't have chest imaging. Nothing was done on the ER as well. I mean, she had 4 ER visits that I could check. No chest X-ray was done. The only test that was done was she was checked for pertussis once, and it was negative, and that's it.
Yeah. And then also with the burn at home, I always think about infectious stuff. I forget what that thing that Harris carried is.
But then I don't know if it would be episodic or recurrent every time.
Most birds cause interstitial disease and
well, there's
restricted
interstitial
disease.
pneumonitis, but then there's this I think it's Mycobacterium. Think of the name of the infectious agent off the top of my head. But anyway, I would broaden my differential to think about the asthma plus and sort of asthma mimickers.
When you look at her admissions, how long is she in for? She's admitted to the hospital. How long does she stay? I'm sorry?
Only for a couple of days.
A couple of days. And is she hypoxic when that happens? Never hypoxic.
Well, I didn't have access to all her reports, but the one I saw, she wasn't hypoxic.
Why'd she get admitted? Does she look good or bad when she gets admitted?
When she was admitted, I guess she looked bad.
What's bad? I mean, this is hard in the chart review. Kind of like, so what about?
I don't know what.
Wheezes don't bring you in. Wheezes don't bring you in.
This wasn't in children. She was admitted somewhere else.
She had only ER visits to children. So we don't know exactly what happened when she was admitted to other places. But I guess she had more severe symptoms, maybe high fever and hypoxia, but I'm not sure about the hypoxia because I couldn't see the records.
And is her pattern of exacerbations changing over time?
Kind of difficult to say. I think it was the last time she was admitted to the ICU was 4 years ago. Currently, she had mostly ER visits. So, seems to be stable 4 to 5 times every year.
She's 9 now.
She's 9 years.
Got it in the ICU when she's 5. What's her cough like?
I don't know. I think mostly dry cough.
Okay. One of the things you look for is honking. Because the kids, I'm intrigued by the fact, I would have imagined she was seen by a pulmonologist at Children's, but otherwise I don't know why she'd have Atrovent at home. Okay, that's a sign that we've seen it. And reading between the lines, there's a lot of interest in irritants as opposed to allergens. So I don't know if you can get more specific about kinds of things that might irritate this kid when she inhales them. But besides the obvious wood smoke and tobacco smoke, the kinds of kids we see that are funny, there are about 3 kinds of kids that we see like this. Kids have malacia. So kids with malacia make mucus, and if you have malacia and you cough, you can't get it out. So you vomit when you're coughing so hard. And they will often be diagnosed with asthma, and they don't respond to beta-2s very much. It's So usually you see atropine steroids being used as the pattern of use, usually by us. So it's an important diagnosis to keep in mind because it's really, really prevalent in subgroups like preemies, ex-preemies, kids who've had central airway disease in the past. There's a real question about whether infection causes malacia, loses tone. Paradoxically, when you're coughing and exerting, it's when you have the most symptoms. And that produces really, really abrupt deterioration. So, it's like, you ever heard The Little Girl with a Curl? You know that poem? There was a little girl who had a little curl right in the middle of her forehead. And when she was good, she was very, very good. But when she was bad, she was horrid. Okay, well, that's what malacia is like. You're fine because you don't collapse your trachea under normal circumstances. But when you start to get sick and you have to cough, then you collapse and you don't get rid of mucus because you collapsed your airway, so you just go to hell in a handbasket.
How do you check that?
We were just talking about a case of that yesterday. An adult, how do you work up to that in a kid?
You bronch them usually while they're lightly sedated. We've been burned if you bronch them when they're under anesthesia, which is what our ENT guys like to do. They're passive and they're not collapsing. And you can't make them collapse, but if you get them pissed off, they collapse down like crazy. And it's an important, when you're looking at labile asthma, I mean, if you talk about this kid's going bad fast and it's fine, bad, that's a fairly classic pattern for malacia, something to think about.
Do you think with expiratory phase before doing that, or?
Everybody does it a little differently. It depends a lot on how much you can actually get them to compress. You can't do it very well with just a passive forced exhalation. You really have to cough. We have a whole stable of people who have been trached for a long time who all have malacia from newborn disease, and they never get rid of it, ever. They get their trachs out, but they still have completely collapsible tracheas. And that's a subjective finding, but it's an extremely dynamic one. So if you occlude your airway more than 50 to 70% with a forced exhalation, you're described as having malacia. Some people say you have to do it only when you're tidal breathing, but there are variations on the definition. But it's a really important component to think about when you hear this kind of fine, really bad in the ICU, fine, really bad in the ICU. And I agree, I call it asthma plus. I don't know where you learned that term, but we use it all the time.
So as they
Do you think an exhaled nitric oxide would help clear
No,
up
I mean, I don't know. If it's high, who cares? I mean, does it make you think asthma if it's high?
Well,
it makes me think atopy.
I've been doing more of them. I don't see kids, but I've seen a number of people recently with normal spirometry and very high FeNO, and I take that as asthma, or at least eosinophilic inflammation, and would not think about other diseases nearly as much. I wouldn't broaden my differential to think this is not asthma.
Would that make you think about a labile process like that? Is that enough information for you to then extrapolate that the person may be a labile asthmatic?
It's enough for me to put them on inhaled steroid.
As a trial?
Yeah. I don't know, other people gaining experience or using it, I mean,
We use exhaled nitric oxide a lot, but we don't use it. We use it as a leaner when we're trying to convince somebody to be on steroids or not. So if it's low, I mean, we use it for compliance, but we don't. I haven't used it in that circumstance with somebody who has a history of bad asthma and is totally fine when they walk in the door. Doesn't help me to decide things. What about you guys?
you have to have access to the test. That's a part of the problem.
Yeah, I mean, we use a lot. We use the measurement a lot. We don't know what to do with it, but we usually use it with a preconceived notion in mind when we ask for the test. Like this parent doesn't want to be on steroids, the kid's got bad asthma, we need to convince her, let's use a nitric oxide.
These kids with malacia, do you expect to see the patterns of the exacerbation improve as they get older and the trachea?
Well, actually, you know, the interesting thing about malacia is that you often have 5 and 6 days of hospitalization. That's why I was asking about duration. So until the process gets over, let's say you get RSV with malacia, you have debris and you have a need to cough and you just don't get better. You don't clear. So the two kinds of kids that are like this, the kids that are tachypnic because they're mucus pluggers and the others are because they have malacia. Both of those are, malacia kids are often tachypnic because of retention of secretions. And I think mucus pluggers are the same way, you know, the reactive bronchorrheics. And those kids often stay in the hospital for long and not 1 or 2 days. So I was listening for that. Hypoxia and prolonged hospitalization make me think about those things.
Do they get hypoxic?
Yeah, the blood.
Yeah.
Do you think this kid is atopic? If I remember, this pre-puncture tests were negative. This is an allergy dilemma. Some people would say you shouldn't do intradermal skin tests. Gary, if he was here, is not doing it, and that's sort of an argument in our field. So you would have only done prick tests. You'd say this kid's not allergic to anything, and the last question there wouldn't be relevant anymore. That atopic disease is not part of this. What are you learning as a fellow about that? Whether we should do intradermal tests, and are we creating atopic disease where it doesn't exist?
I don't know. I think if on the other hand she had severe exacerbation and she ends up in the ER every time, so maybe we can try and control any environmental trigger that's around her on the other end. And we can ask the same. I mean, on the other way, you can ask whether or not you want to put her on immunotherapy and try to reduce any kind of inflammation that she might.
I agree with you, but I mean, what are you doing here at the university clinic as far as intradermal testing?
I'll do them occasionally, especially if I'm thinking of putting someone on immunotherapy. You know, if you're missing something like dust mites, the risk of missing it is much higher than putting it in their mix if they don't need it. So I will rarely do it. We have several intradermals that we'll use occasionally, but it's not something I do routinely.
And if the clinical history is good, and also if you want to make them a candidate for anti-IgE therapy, maybe you want to do this.
That's another tool.
So that's the question I had here. Would you? I mean, you don't have an FDA approval, but could you get an approval to use Xolair in this patient?
Well, you could check an IgE and see where it is for a start.
Because you've got the positive intradermal to perennial
I
allergy.
thought IgE was what dictated your dosing.
Yeah, you need a level.
But what was the IgE in this patient?
IgE. We don't have no IgE.
You only have to get to 30. You can get almost anybody to 30.
Have you had any trouble using that in this age group?
Yeah, well, we've used it in kids 12 and up, and we've actually used it on a couple of kids lower, but not very often.
And it's a 9-year-old, so
Yeah.
that wouldn't be a problem.
It would be a problem. It would constitute it would slow us down in the process of it. When I look at these kind of histories, I worry about what's perceived as distress. Who perceives it? Besides dyspnea, which is what a child can perceive.
I think it's a coughing.
But a lot of people cough, so tell me more. I mean, kids come in the ER, and the one you just showed me said, he got a little retractions, he sounds good, he's good enough to give him some Dex and go home.
But she was seen at the urgent care earlier, and somebody thought she was bad enough to put her on steroids.
Well, that's not hard. That's if you come in, you get steroids. So
every VCD patient comes in and gets
right.
steroids and MD and whatever.
She's too young for VCD in the classic sense.
But
that's why I was listening for more physical findings on this kid.
Yes, and we don't have it documented.
Yeah, but tussive emesis tussive emesis is common, but not so common in 9-year-olds. So does she have regurg? Does she have, makes you think about asthma plus again. I don't know that I would be suspicious about this just being asthma. I think your pheno is not a bad idea, but I'm not sure what I'd do with the data.
Well,
if it's 35, I go, okay, it's right in the middle ground.
I mean, sometimes I said somebody yesterday had a normal spiro and a pheno of 260. So
is this a kid you do a methacholine challenge on?
I could. I just accepted it as eosinophilic airway inflammation and put him on an inhaled steroid. That's a good thought. Didn't have time to get a methacholine.
Yeah, if the kid had a negative airway challenge test, would you still call this kid asthma?
With a normal methacholine?
Mm-hmm. Normal spiro, normal methacholine.
Then you'd have a hard time calling it asthma.
Right. See, I think that would get you more toward a diagnosis of trying to characterize better what you're really dealing with, and I'm not convinced yet it's asthma.
Now, in fairness to David, I asked him to pull this case together pretty quickly, so he doesn't have all the answers.
No, I don't have
No, no,
I'm
and
sure
it's-
he's seen the
She was
patient.
saying last week that Paul Williams actually saw her, so we don't have all the information. I tried to check her Seattle Children record, so that's what I had, but I don't know what happened on the other admissions.
Can I ask you how often you guys are doing airway challenges? We've not done them routinely. And we're thinking about adding methacholine to our armamentarium, but we just haven't used it in our practice. You know, in 5-year-olds it doesn't matter because they can't do it. So how much are you using airway bronchial hyperreactivity assessments in your practice?
Well, in adult population, we use them. I mean, this sort of situation, chronic cough, we can go right to that to see, they have a history of asthma, but it doesn't really fit. So,
Got it. Okay.
I mean, we do a fair number.
Do you?
Pulmonary function life or not.
Okay.
Sometimes we just give them an inhalants, yeah.
I use it for the VCD question.
Uh-huh.
Often, when I think they probably don't even have asthma.
Got it. Okay.
That's kind of a subset.
I mean, I found it at Virginia Mason, where David and I rotate occasionally. They use it a fair bit, and I found it fairly useful there for cases like this, obviously in adults, but where you're questioning the diagnosis.
That's where you're questioning the diagnosis.
Right.
They do it right in the clinic there. So
I think in this case it's helpful in terms of ruling it in.
Yeah.
I don't think you ignore the plus part of asthma plus.
Right.
And you still look for that as well. So what besides asthma is contributing to the lability of this kid's disease?
If you've got an asthmatic, a 9-year-old like this, asthma, and let's just say she's just a plugger. This is what gets her into trouble.
Mm-hmm.
She gets sick, and then she plugs.
Yeah.
How are you treating those kids? I mean, in between those episodes, they're perfectly fine. So you keep them on a...
So I don't think there's a difference in terms of, so we've got about 10% of the kids who come into children's come in with tachypnea, minimal retractions. Your kid didn't have tachypnea, but come in with tachypnea, hypoxemia, minimal retractions, and more inspiratory work than expiratory work. So they don't have a prolonged expiratory phase. And nobody knows what to do with those kids. And half the time they've got atelectasis, and they're called recurrent pneumonias. And we've come, this is over a lot of years, but we've come to call them pluggers. And they make mucus, and they plug their airways, and they respond to albuterol. We haven't done exhaled nitric oxide on that group to see what they're like, but they respond to pathways for asthma, but over a prolonged period of time of usually 4 days. And when we did this in the 80s. If you take the kids who come in with atelectasis as part of their, quote, asthma exacerbation, and you follow them up and they have clearing radiographically, that for every next time they come in, and they come in sometimes often, they will have atelectasis again. 85% of them will have atelectasis as a recurrent pattern for their illness. And that's where we got into the mindset of calling these kids pluggers based on hypersecretion, airway plugging, atelectasis, and not just bronchospasm. And in fact, their expiratory work is usually not very great. They're tachypnic because they're plugged. So if I plug your right main stem, you'll breathe fast. Okay, you won't necessarily wheeze, but you'll breathe fast because I just took out one of your lungs. And so plugging leads to a restrictive pattern of breathing associated with respiratory distress, usually in the face of a viral illness. And we've called those kids pluggers. They're often atopic, so they look just like asthma in every sense outpatient. And they come in with recurrent plugging as their manifestation. And we treat them harder, so I usually just bump their steroids, and sometimes we'll play with anticholinergics, but I'm not sure it makes much difference in inhaled steroids. So we treat them as if that's their manifestation of asthma, and you should treat their asthma more aggressively so they don't have that manifestation of acute illness.
So you keep them on high
Do you add novice to that?
Not always. Not always. I mean, I'm not convinced that we have in some cases in the old days. We do it less, but you can. I mean, I treat them like they're asthmatics, and by the way, they plug. So let's just treat them and get their asthma as good as it can be, so we don't have a bad exacerbation when they get sick next. But those kids will usually present with tachypnea, a little bit of retraction. They don't have time to retract a whole lot, and usually hypoxemia. And their radiographs can be abnormal or not abnormal. But if they are, it's a little sliver of something, and half the time they come to us as recurrent pneumonias.
other comments?
Have you been doing serotyping in the rhinoviruses, like Robert Lemansky's work with there's some serotypes?
We talk a lot. Rhinovirus is probably the biggest. Now that we're doing PCRs for rhinovirus, we're finding it to be a huge actor in inpatient wheezing in all age groups. And our RSV negative, human metonymin negative wheezers that are less than 5, a ton of them have rhinovirus, and it is a bad actor. And they have residual wheezing thereafter. So Lemansky's group has said, you wheeze more at 3 to 5 if you've had rhino in your first year of life, or the co-study.
And there's some of the subtypes that
Yeah, rhino C. Yeah, but nobody's doing A, B, and C subtypes right now.
No.
But we're seeing a ton of bad rhinovirus, lower respiratory disease.
Can you go back and type those out?
I don't know if anybody has the interest right now. We talked to ID about it, and it's just, yeah. So it's not generated enough interest to do it.
So Paul Williams is going to follow this patient? Yeah.
This patient up in Mount Vernon, or yeah? Did you see the patient, or?
I'll see you next time.
Okay. So you presented the case blind, so you did a good job. Thank you.
Yeah, nice job. Thank you.
Greg, thanks very much.
You're welcome.
Spending the morning with us.
Pleasure.